Hello, everybody, and welcome to the Modern Medicine Podcast. I am your host, Dr. Dennis Tian. Welcome. This is the place to be if you're interested in healthcare, you're interested in medicine, and you want a little help navigating the sea of information that is out there regarding your health, your body, and your wellness. Joining me, as always, is David Yaz, my producer. Dave, how are you?
Not too bad, Dennis. Weather's nice and exciting to have a guest in studio on the show.
That's right. A new first for the Modern Medicine Podcast. We have our in-studio guest for the first time, Dr. Stephen Rotman of Beth Israel Needham, Gastroenterologist. There you go.
Excellent. Great. I'm doing great. Thanks for having me.
I'm so happy to have you. We've been trying to work this out for
this is great.
A couple months to try and figure out a time, and we finally were able to do it. So kudos to us.
This is great. I love your platform. I love your focus, trying to get good information out to folks. That's what we need to take care of the community.
100%. And you know that because, we live in a culture of misinformation right now. And especially when it comes to health and medicine, we deal with this every day. So, I think it's really important that we get good, accurate, honest information out there for people that is unbiased, unfiltered. We're not trying to sell anyone anything. We're not trying to push any agenda. Just trying to give people, some info.
Absolutely. I'm with you.
Awesome. All right. Well, we got a great roster of topics tonight. We're gonna talk with Dr. Rotman first about his practice and some hot topics in gastroenterology, latest in colonoscopies and some alternatives maybe that are coming down the pipeline, a couple other hot topics in gastroenterology that I think people will be interested in. We've got some great stuff in the news. A woman that was poisoned by a common supplement that a lot of my patients are taking right now in there. And then, of course, some interesting stuff about our president who never seems to not produce something for us to talk about. And then we will have the non-medicine topic of the week, which, of course, we have to talk about Coldplay. And the viral of all viral sensations. You talk about viral sensations, right? And that was it. So we're going to get to that. And if we have time, we might hit another topic or two. How's that sound?
Love it.
Awesome. Well, let's get to it, my friend. Let's talk a little bit about your practice. Tell me, you're relatively new to this area. So tell us about your practice and how you ended up in Needham and where you came from.
Yeah, that's great. Again, thanks for having me, guys. This is awesome. I think it's really a great resource, both on the local level and for everybody that we can reach, and you're doing a service with that. So thanks for having me. Always happy to chat about kind of the dirty work of gastroenterology. I know you've got lots of patients with all different medical needs, and many of them probably have GI concerns that you deal with on a daily basis. So happy to share. So I am a local guy. Grew up in Massachusetts, in the Sharon area. My medical training.
Wait a minute. Hold on. Producer Dave's from Sharon. Have we played this game before? Did you go to Sharon High?
I sure did. The old Sharon High.
I didn't.
Been by lately?
I didn't. No.
Right.
But I have a feeling I'm older than you. So, I'm 56.
Yeah. So we wouldn't have overlapped.
Okay. Well, I'm old. That's the conclusion.
I didn't say that. That's not what I said.
We'll play the geography game. I grew up on Country Lane near East Elementary.
Oh, nice.
A bunch of stuff.
Near the police station.
Okay.
Yeah. I go back sometimes, but very good. I love it.
Well, you're welcome back anytime.
Oh, all right.
Even though I live in Foxborough.
All right, that's fine.
I'll meet you there.
I didn't say anything noteworthy yet, and I'm already invited back. So
there you go.
I like that. So medical training, I was a resident and a medical intern at New York Presbyterian Cornell's Hospital in New York City, then came up to Boston to do a gastroenterology fellowship at Brigham and Women's Hospital, back to New York to do a year of what's called advanced endoscopy, therapeutic endoscopy at NYU, and then came back to the area in 2017, started practicing at Milford Regional Medical Center in Milford, Mass. I was there for about 4 or 5 years. I live closer to the Needham area, and an opportunity presented itself to join the staff at Needham Gastroenterology Associates and the BI in Needham, and that's where I've been since 2021.
There is no shortage of demand for gastroenterology services. I was just talking with you before we went on the air, and every GI practice I've ever worked with, they start off, doors open and they fill up fast.
Yeah, one statistic I like to talk to folks about in the office is if you think about something like functional GI disease, which is a term that a lot of folks might not be familiar with. If I say irritable bowel syndrome, or I say constipation, or I say diarrhea, we're talking about 25% of the population in the U.S. And we can dive into why that might be. But be that as it may, 25% of the adult population having some GI bowel functional issue is a lot of patients. And a lot of people get great care from their primary care docs, but it's tough for you guys to spend the amount of time in a conversation really going through the stuff that we are able to have the time in an entire appointment to go through. But you're right to say lots of needs. And to tell you, one of the things that brought me to gastroenterology was the fact that we deal with a lot of different problems, right? We deal with the esophagus, the stomach, the small bowel, the large intestine, the pancreas, the gallbladder, the liver. I mean, it just goes on. And so there's a lot of variety, which I enjoy, but it also brings a lot of needs to our office.
One of the things I think that most people think of when they hear gastroenterologists is colonoscopy, because one of the reasons I think all the gastroenterologists are so busy right now is because those guidelines recently changed. And it used to be that for most people would get their screening colonoscopy at 50, and now it's at 45. And I think one of the unintended consequences of that is that it's really increased the demand for your services.
You're right about that. And we're going to go through a lot of things, I'm sure, this evening, Dennis. One of the things that would be the take home is what we're going to talk about now, which is the importance of colon cancer screening and the role of colon cancer prevention. I see lots of patients in my office, younger folks, middle-aged folks, older folks who want to be proactive about their health. And this is an area where we can really make a big difference. And the reason is because colonoscopy can reduce the risk of colon cancer. Any guess?
A lot.
70 to 80%,
significant.
right?
Yeah, I was going to say
70 to 80%. Yeah, you'd be close.
Yeah.
So there is not another screening test for any malignancy we know of that comes anywhere close to that.
We'd say in medical school it's high yield.
High yield, very high yield.
So get your colonoscopy. That's the clear take home. And you know, one of the challenges that I face, because every physical we do, we send them to you guys if they're over 50 or 45 now, excuse me. Getting people to go for their colonoscopy is much harder than referring them. You know, people don't want to do it. It's a tough procedure. It's not a super invasive procedure, but it's not a walk in the park either. You know, the bowel prep is difficult, everything. So my question for you is like this holy grail of alternatives to colonoscopy that I keep wishing and dreaming for my own personal selfish reasons too, because who wants to do another one, that there's going to be some test that's actually an alternative that approaches the effectiveness of the gold standard of colonoscopy coming, a blood test, an MRI, some 3D AI crazy thing. Is there anything like that you think coming down the pipeline to replace colonoscopy, or are we just, you know, resigned to have to do this every 10 years for the rest of our lives?
Sure. Great question. And we could spend a lot of time talking about this, and we can. I would come at it from a different perspective, which is to say, from my perspective, the test is so high yield and so important that whatever that price is to do so, the prep, the day off of work, the diet beforehand, really is nothing compared to the potential of a misdiagnosis, right, that we could deal with. There have been different modalities over the years, starting with people that used to just test the stool for microscopic blood or doing little exams called sigmoidoscopy, where we only go up a little bit to look for malignancy in the rectum. Colonoscopy now is decades old. It's tried and true. The prevention data is really clear. And the reason is because not only do we identify precancerous lesions called polyps or adenomas, but we remove them. And it's the removal of those lesions that makes it so they can't grow over a period of time. Now, the most recent thing down the pipeline has been the Cologuard, right? Which is which is a stool DNA
they're
test.
In my office every month or two.
I'm
bringing me lunch.
The reps.
Oh yeah.
So I could give you my entire spiel on Cologuard, right? I think there's a role for lots of different testing.
Right.
What I would say about Cologuard is a few different things. The most significant thing I like to talk about in this regard, because we talk about options in the office when I meet patients for colon cancer screening. First of all, if you're at all an increased risk patient, you don't qualify.
Right.
So if you have a family history of colon cancer, if you have family history of certain types of polyps, you don't qualify. If you have symptoms, you don't qualify. If you have had polyps before, you do not qualify. All right. But what I say is, I do colonoscopy however many 1,000 times a year.
Right.
And I hope that I never find colon cancer.
Right.
That's not the point of a preventative strategy in healthcare. Cologuard's big claim is they detect 90 some odd % of cancers.
Right.
Again, that's not preventative to me.
Right.
Preventative to me is finding the polyps, taking them out before they become
100%. And if you look at the limitation of Cologuard, it's in precancerous and early cancers. And by the time the cancer's advanced, you know, the positive predictive value goes way up. But in the early stuff, it's really the data really isn't very good.
You're absolutely right. The data in some studies show that larger precancerous polyps are missed by 40% of Cologuard tests.
Right.
That's not so good.
Not very good at all.
And even upwards of 10% of cancers are missed.
Right.
In some studies. So it's a mixed bag.
It's a mixed bag. You know, the thing is, like, there are just some patients that will not do their colonoscopy. And it's like, all the things you're saying, we tell them, and it's like, there's just no reasoning, you know, with some people about it.
It's tough because it's invasive. It's an intimate type of exam, right? The best advice I can give to you, to other referring docs, and to patients is to say, if you have hesitation, come and talk to me.
Right.
Get yourself into a GI office.
100%.
Have a sit-down conversation, and let's talk about it.
Make a conscious choice.
That's right.
Like, have the conversation. Don't just do it out of fear.
That's right.
Or the unknown, or fear of a procedure that's really a minor and quite routine procedure that you do, 20 in a day when you do them properly.
We do it a lot.
Right. So I always try to encourage people, look, at least have the conversation. Know what your terms are. There was a study in JAMA, I'm sure you saw it maybe a few weeks ago, clinical validation of circulating tumor DNA-based blood test to screen for colorectal cancer. This is what jumped out at me, and I think you'll agree with this, but tell me, but 79.2% sensitivity, 91.5% specificity for advanced colorectal neoplasia using colonoscopy as reference standard. That's not very good.
It's the same argument, right?
It's not very good. Right. Colonoscopy is like 99%.
Right.
It's gold. It's a true gold standard test.
Yeah. I think until humans stop making polyps, adenomas, precancerous lesions, it's going to be tough to beat colonoscopy. I mean, technology advances, medical science advances, and things might come around. I don't think we're on the brink.
So maybe, so maybe AI will do the colonoscopy, but it's not going to replace the colonoscopy.
Yeah, it's funny. I was going to ask for your take on some of the AI stuff in the news lately. And I think about it in the GI world sometimes. There's stuff that's been out for a while with colonoscopy, for example. You're on our big screen that we're examining the colon. There are programs that will match the image in real time to a photo library.
Yeah.
I think it's great maybe for folks who are lower volume providers, new graduates, things like that. The stuff that I've seen it pick up are really quite small and often inconsequential. And I mean, we're not missing, for the most part, docs are pretty good at not missing significant lesions.
I wish every test was as effective as a colonoscopy.
But you're right. It's still, there's a barrier of entry, right?
Yeah.
It's also, if you send me a patient and they call and they're going to be in 5 months,
right?
That's a barrier of entry.
That's a barrier of entry, and 5 months isn't even that bad in today's world. And then there's just there's this thing, especially in men, to be honest, like, oh, you're not doing that to me. Right. It's like we're trying to save your life. Do you understand? We're saving your life. You can be knocked out. You are knocked out for this. You don't feel anything. This is life-saving potentially. It just doesn't register in some people.
I know. And again, that's where maybe the conversation with someone like me in the office, we sit down for 15 minutes, we talk about it. You're right. I mean, it is good to inquire with your provider. Some places use one type of sedation, other places use another. You want to know what you're getting into. Where in Needham at the BI, we have full anesthesia support, meaning folks are not under general anesthesia. They're breathing on their own, but it's a very comfortable experience.
100%. And I would say that if you are in the area looking for a colonoscopy, the facility there is gorgeous. It's brand new. It's right across from the hospital. It's local. I mean, if you want to make that whole experience as pleasant as can be. And it is a reasonably pleasant experience. The staff is friendly. The building is nice. It's a great way to do it.
Agreed.
So you hear that, Producer Dave? We're doomed. We're doomed to colonoscopies.
Oh.
The robots will not be taking over on this one.
No,
Yeah,
not for now.
I don't want robots in that part part of my body. I don't think.
I agree with
no,
you.
Thank you.
Fair.
The human experience
Sounds like
still
bad
exists.
sci-fi movie.
Right.
Okay, so one thing that on this topic, we talked about screening colonoscopy, but one thing that comes into my office a lot, there's just certain complaints or experiences that I would say are like the human condition, and that everyone that lives long enough is going to get this, like vertigo or back pain or a headache. But I would put rectal bleeding on that list. Every single person at some point in their life, I think, has a little blood down there when they go. When should people be concerned about rectal bleeding? And I want to ask it because it's just such a common symptom. Nobody wants to talk about it because it's uncomfortable. If you go on the internet and you Google it, if you're a layperson, prepare to be scared.
Scary. Yeah.
But the reality
That's
is
right.
it's usually pretty benign.
Yeah, that's
when should
right.
people be worried?
Yeah, great question. And that's actually a moving goalpost, right? So decades ago, a young person without risk factors comes into an office and says, "Oh, doc, I see a little blood in the stool. Or when I clean myself, I see the blood." I think back then people would say, hemorrhoids, it's an irritation down there. Don't worry about it. Now, because we're seeing polyps and growths in younger and younger people, we're less inclined to do that. And so evaluation for rectal bleeding, more often now, there's a recommendation to take a look with a colonoscopy or a sigmoidoscopy to be sure we're not missing something bigger.
Right.
But to answer your question at large, you're right. Most of the time, it's going to be something benign. Hemorrhoids, irritation, fissures. There's a bunch of different things. So I think seeking care is always a good idea if a new symptom like that pops up. Now, if people who've had colonoscopy recently, say within the last couple of years, have a little bit of bleeding, that's unlikely to be anything sinister. If folks, again, have had an exam before, they have no risk factors, and maybe it's a little bit, they tell you they've been pooping 10 times a day and they're cleaning themselves nonstop. I mean, there's certain commonsensical bits to it, but oftentimes making sure you're not anemic in your primary care doctor's office is really important. So I think it pretty much always at least beckons a conversation with your primary care doc and sometimes with us in the GI world.
100%. And, I mean, what I look for is like persistence, right? If someone comes in like, oh, it happened for 3 days and then it went away for 2 weeks, I don't really worry about that.
Sure.
But when it's persistent and progressive,
that's right.
That's generally where I get a little more concerned, more likely to refer to you. And I'm not going to obviously say anything identifying, but I'm thinking of a specific patient I sent you a few weeks ago who came in and it was just, it's getting worse and worse and worse. And turned out that patient had rectal cancer.
Right. That's right.
So you do see those ones. But so much of our job is like finding the zebra in like 1,000 horses. 1,000 people come in with rectal bleeding, dysphagia, back pain, headaches. They're all fine. And then who's the one out of 1,000 that's not?
I know. It's so hard. And that's why I try to keep in mind that our job is still a human job, right? And it's about that relationship with the patient. And that's where I think artificial intelligence is missing out. Those folks who are very bullish on AI in healthcare, it's still a human experience. And a lot of the time, what I'm doing, what you're doing, we're coaching, right? We're sitting with our patients. We're either encouraging or we're coaching or we're, confirming thoughts or whatever. We're not. We want to make sure we're not missing that zebra. But so much of the time, we're there to. And remember what physicians were way back when in the villages. They were the people that sat with the sick patients and held their hand. They didn't do much. They didn't have medicines. They didn't have surgery. They didn't have colonoscopy. But they were the people that were there to try to lend a hand to their common men and women, right? And so I try to keep that in mind, and I think that's what we'll lose out if you go into a doc's office and you're talking to a screen, and the screen's telling you take this, and you got nobody to talk to. I mean, that's the fear I have.
Yeah, and it's like, I mean, there's a lot of what we do that is just like that human side of things, and just like, so much of I feel like problems, I mean, yeah, there are objective real problems, of course. But then there are a lot of times where people, their experience of their problem or of their not problem, as it were, is just way worse because of the human factor. And so much of what we do, or I do for sure, is reassure people and based on our connection, our human connection and the trust that they develop in me and in my people that work for me, that we are giving them that reassurance that, everything is okay. And like, I mean, I check 1,000 thyroids a year. I probably pull like 5. That is actually wrong. Everyone comes in my office, they're tired, they're stressed, they're, how many, we check everyone's thyroid. Most people, it's not your thyroid. You know what I mean? There's nothing wrong. So it really is about that human connection a lot of the time. I want to talk to something you just hit on, which is the rates of GI cancers in younger people, which is like a hot topic right now. And, colon cancer rates in particular are really on the rise in people under 40, not just 50, 40. We're not even screening these people right now based on current guidelines. This is why the guidelines changed a few years ago from 50 to 45. Why are so many young people getting colon cancer?
So that story remains unwritten a little bit. But if you ask me, the biggest reason, which has been neglected in this country for too long, is nutrition. I think it's nutrition. We can have an entire podcast on this, and we can talk about it a little bit tonight. But our food supply that we've been fed for decades is so poor. Right. And there's data to support processed food relationship with colon cancer, early colon cancer, also, or younger folks. Some relationship with red meat as well. Right. But if we really focus on the processed food bit, it's an epidemic. Right. It really is. And I think that's the biggest actor.
100%. And we've built a whole food system around processed food. And it's so unnatural. Our whole bodies are not meant to metabolize. It's from like our insulin responses to on a cellular level, right through like how these foods pass through our intestines. And just think of your whole life, all the time you're eating that processed food, and it's like irritating and slowing mucosa and irritating that mucosa. And that's really what's engendering, right, all these like cancer cases. It's all that tissue damage.
It's hindering your immune response to things. It's, if you think about it in, I see folks every day for so-called fatty liver disease.
Oh, this is going to be my next question.
Oh, good. All right. You want me to wait?
No, go for it.
Go for it. So fatty liver disease occurs when you get some fat deposition in the liver tissue. Right. And if that progresses, that fatty tissue replaces normal liver cells. Right. All right. And can lead to scarring and ultimately can lead to liver failure. Right. Fatty liver is extremely common. Why? Because of our food supply, we don't think about metabolism on a cellular level enough at all. Right. So what happens is the liver cells, the hepatocytes, take in these huge loads of sugar that we find in, because all processed food is just filled with sugar.
Right, or it becomes sugar.
That's right.
And becomes sugar in your small intestine.
That's right. And your liver cells can't keep up, can't metabolize it the way that we can efficiently do so, and it all gets shunted to other pathways that often produce this fat. But it's the same thing. It comes from the food supply, and we really need to think about it in this sort of, how do we improve our metabolic function on a cellular level, and that affects the whole organism. And that's just one example. But the colon cancer stuff, I think, is related.
Yeah, it's all part of the same thing because of the way all these foods are affecting our metabolism and just being so unnatural. You know, Steve, I tell my kids and myself, I actually think it's better to eat sugar than it is to eat processed food.
Probably.
You know, I mean,
you can control it a little more.
If you eat like a bowl of like processed, like a food of like processed carbohydrate, like some highly refined grain, that sends your blood sugar through the roof worse than like a real natural sugar would, in my opinion. And I think it's been validated in studies. So I think that there's nothing worse than processed food. Like, you know, table sugar is sucrose, which is what? Glucose and fructose, I think, right? You know, I mean, you take like a chain, like a piece of bread that's like super refined, right? And grain that's super refined. That has no table sugar in it. But all those carbs get sliced up into glucose as soon as you get into your small intestine, and your blood sugar skyrockets.
And you hit on it. You hit on it. You said the insulin is out of control, and that's exactly right? Because there's a lot of research that shows that the insulin spikes that we get are pro-inflammatory.
100%. Oncogenic.
Right? And
fancy way of saying promotes cancer cell growth.
That's
if you're
right.
not medically trained.
That's right. So the more loads of insulin that our body's being hit with is detrimental for all those reasons.
And this is why there is some preliminary data now that drugs like Wegovy and Ozempic might actually have some role in cancer treatment or prevention. That's very preliminary and not great data, certainly not mainstream yet, but there is some preliminary data on that because of this exact reason. Like insulin dysregulation we talked about this when Charlie Dow, the cardiologist, was here. It's one of the worst things that can happen. It's a metabolic, physiologic, systemic syndrome that affects its tentacles in so many different places. It's one of the worst things you can let happen to yourself.
That's right. And you don't have to be, for example, obese to have metabolic dysfunction, right? Nope. You can have people who are normal weight, normal BMI, and their cells are just in terrible shape.
Yep.
And you can, by the way, have folks with elevated BMIs who, for whatever reason, their cells are not
110%. I have a patient that looks like I have a couple that look like they can run marathon tomorrow, and I can't get their A1C below 11. Their blood sugar anywhere in the range of normal.
That's amazing. What are the folks that come into your office inquiring about GLP-1s thinking, are they mostly still thinking about weight loss benefit, or are they now getting into the weeds a little bit? I'm curious.
Still weight loss benefit, mostly weight loss benefit.
Yeah.
I look, if someone has metabolic risk factors for heart disease and they've had them for 10 to 20 years, it's a safe bet they have some extent of heart disease. So if I can use that as like a Trojan horse in a positive way, okay, you want to lose weight, I'll get you on Ozempic, knowing that it's going to probably be protecting their heart too, then I'm all for it. But it's that sort of ancillary cardiovascular benefit that I like. But the majority of people are still looking for weight loss, and we turn a lot of people away because it's like, look, you're 32, your BMI is 27, we can't give you Ozempic. Right. Then you're not going to get coverage for it.
That's right.
You know?
But we can do something, which is to eat better.
Right.
And again, I come back to the coaching bit and the sort of support role that at least I play 100%. In a GI practice is, let's sit down and talk about how can we eat cleaner. 100%. What does it mean? It means things in packages, not great, right?
And those medicines work best when they're made in the context of lifestyle changes.
Absolutely.
The patients that get the best response are the ones that actually change their lifestyle and exercise. And
I mean, my concern with the GLP-1s is still that people are not doing those things.
Oh, no.
And so to affect positive change holistically, we need to think about what the root cause is, which is, again, if we're talking about the diet, but what happens long term? Are they dependent on it? How long can you be? I mean, there's still a lot of questions, but
there are
certainly, as you said, look at the oncogenic benefit, maybe in addition, of course, to the cardiac endocrine benefits. But I think the other thing it does is it just slows as we said, the load of glucose coming into your bloodstream because you're eating less.
100%.
Right. So it's helping to. I would just like to think that it's promoting better behavior, and that's the goal. I would think.
And patients that are on these medications and then try to overeat, they get sick.
Sure.
Like they can't do it. Like
right.
they don't feel right. I want to talk one more thing before we move on to In the News. I want to talk a little bit about fatty liver because you just brought it up, and it's a great topic to talk about because so many people have fatty livers now. And, we do a lot of metabolic panels on physicals in older adults, middle-aged adults, rightly or wrongly. That's sort of what people expect. It's the standard of care. And we get back a lot of people with elevated liver enzymes. It is actually shocking how many people, and a lot of the pathologists, they continue to lower the bar for how they flag these as positive.
Yes, you're right.
It used to be 70 for your AST and LT. Now it's like 40, and people see it on their portal. It's red. It says abnormal. It really freaks people out. I get these people, right? I'm like 99% sure they have fatty liver. But what do I do with them? I'm looking for the zebra. Do I send them to you? Do I send them for imaging? Do I, it's tough.
So exactly right. I think that I have no problem with all of your fatty liver patients coming to our office. I think that having you in their corner is huge, and having a GI liver doc in their corner is also huge. I think it can help keep them on track. We do a test called a FibroScan test, which is a type of fancy ultrasound called elastography, which looks at how stiff or squishy the liver tissue is.
And you do these right in your office.
We do it in the office, and it's painless, it's non-invasive. But what it does is it allows us to get a sense of what's the degree of steatosis or fatty infiltration in the liver, and what's the degree of fibrosis or scar tissue in the liver.
Right.
Scar tissue in the liver is when we get a bit more alarmed.
Yeah.
Right. But to your point, you're right. I tell people when I meet them for the first time with fatty liver disease, I say it's a spectrum.
Yeah.
Lots of people are here. Some of these fatty changes all the way up to liver transplant, right? Leading cause of liver transplant nowadays. Right. Let's keep you on this end.
Right.
But we do that by monitoring your liver enzymes a couple of times a year. We do your fiber scan. Nowadays, honestly, fiber scans can be done once or twice a year for patients really wanting to know what the progress is like if they're on a weight loss program or whatever. But it's huge. And I also tell people, not to scare them, but I say when your liver, when Dr. Tien does your liver test and two of the enzymes are elevated, the AST and the ALT, that tells me that your liver cells are inflamed.
Right.
That's what it represents. The hepatocytes are inflamed. And the more inflammation goes on in those cells, there's the risk of the scar tissue formation. So it's these kinds of things that are just so nuanced that you have to take care of every part of the patient, right? I get the privilege of saying I can focus on just whatever that one thing is. So these conversations are so important, but that's why your podcast here is so important, because you can reach people that we can try to explain a bit.
Well, that's just it. And I think if someone has fatty liver, they should certainly have a conversation with their doctor about what to do. I have to say, I don't send every patient out for referral. I mean, it's kind of a judgment call. I think what we do, if someone comes back and they have liver enzymes that are elevated, we usually do a telehealth visit and we discuss it with them. We kind of lay out their options for them. And a lot of times the right answer is just to do nothing except the same stuff, which is lose weight, exercise, control your, fix the insulin dysregulation. If the patient's diabetic or pre-diabetic, I mean, if you got a 300-pound person with like an A1C of 6.4 who comes in with the AST and ALT of like 72, I mean, I could literally fill up your office 5 days a week with people like that. I can't send everyone out.
I agree.
So it gets tough in that situation. But at the same time, there are some people that want to know. There are some people that concern me a little more. At the end of the day, the answer is usually the same.
That's right. You're right.
Take better care of yourself.
What's the trend? Is it worsening? If it's worsening, those folks should probably see a hepatologist. Is there something concerning on an ultrasound they should see? But you're right, most people don't, and that's reasonable. But you're right, a lot of it boils down to what we're talking about, which is how do we improve our metabolic health?
Right. It's just, I mean, like you said, you focus on one part of the body and you see the manifestations of this, poor lifestyle, unhealthy lifestyle in what you do. We could have any number of other specialists in here. They would all say the same exact thing.
Absolutely.
So
that's right.
I think that's a take home. Producer Dave, you got any questions for Dr. Rotman before
Sharon
we go to in the news?
Sharon High related.
I'm trying to think of a question that covers Sharon, Massachusetts, and gastro.
They said we had a good water supply when I was growing up.
The water was fine, right?
Yeah, it was pretty good.
The lake was kind of suspect.
Really?
Lake Maspog was one of my favorite places to swim.
Kennedy used to vacation in Sharon.
Did he?
The air is good up there. It's a little higher elevation.
Yes.
I'm serious.
So, did you ever hit a home run in Deborah Sampson Park?
Oh, I was there I actually played before they put the fencing up, I remember.
Yeah, me too.
But then we had like the plastic fencing, and then they built the real one.
Now it's super nice.
I think I put one out once or twice.
All right. Well, that covers all my questions.
Excellent.
I'm due for a colonoscopy, so
in
case I needed convincing, I got it all here today. So
100%. We can set you up. We can set you up with Dr. Rotman.
That's right.
All right.
All right. Well, let's move to in the news. Are we going to play our fancy new song we have from last time?
You bet we are, Dennis. Here we go.
In the news.
All right.
All right.
Let's do it.
This is it. This is the high production values we have here in the Modern Medicine Podcast. So, first story in the news. This is a great one, actually, right up your alley.
Oh.
Woman says, turmeric caused liver damage from over ingestion of turmeric. This is a story on NBC News. Katie Mohan started taking daily turmeric pills in March after its benefits for inflammation and joint pain relief. Excuse me, I knocked something over. The 57-year-old started having stomach pain, nausea, and fatigue. Just didn't feel well generally, she said. I noticed this despite drinking a lot of water every day, that my urine was darker. Long story short, she had liver damage, transaminitis from overdose of turmeric she was taking. I think 10 times the upper acceptable daily limit.
I think it was at least, yeah.
Yeah, more than 10 times the upper limit of turmeric.
I think...
you ever heard that one before, Doc?
I saw the same story. I think my mantra, most things in moderation, would apply here.
100%. But I don't want to say I did a deep dive. I definitely didn't, but I did a little
Shallow
bit
dive.
of a shallow dive, if you will. That's my patent. That's my trademark.
Love it.
The TN shallow dive.
Love it. Love
And I mean, where is the evidence that turmeric is really good for anything? Like all this, like these theoretical studies based on like how cells in vitro might respond. And where is the actual in vivo population, epidemiologic, real quality evidence that turmeric benefits anything to make you think to even think about taking it in that quantity?
I wish I could point you towards the studies, but I too am baffled.
Right. 100%. There's one study I found, and it was a poorly done small study that said it might have some benefit towards joint pain, or people on turmeric might have a little bit less joint pain. This is one study for joint pain. So, it's funny because, people want to take it because it's supposedly anti-inflammatory, anti-cancer, anti-diabetic, anti-diarrheal, antimicrobial, antiviral, and antioxidant properties.
Perfect.
And it's like, yeah,
Does
perfect.
everything.
It does everything. And I tell
That would make you play piano.
I mean, you know what else would kill cancer cells in a lab petri dish? Bleach.
Yeah,
You're gonna go
bleach.
drink that.
Right. That's right. That's right.
So it's kind
I don't get
of
it.
it's kind of crazy, but people, it's crazy what people will put in their body, without really any evidence. This whole supplement thing, it just drives me crazy.
I know. It's we didn't talk too much about it, but it's almost like the probiotic world.
Oh
right?
yeah, I was going to ask about that.
Yeah, the probiotics are a multi-billion-dollar industry, and folks often ask me about it.
Yeah.
And I say, most of the time, with a few exceptions, I say, it's probably not going to hurt you. I can't show you evidence that it's going to help you.
Right.
And if you want to give it a shot. But I tell people, if you do it for a month and you don't feel any different,
Right.
stop spending your money on it, right?
But it's fair to say the studies really aren't there.
That's right.
Showing the strong
and
benefit
listen, the
of probiotics.
microbiome or the population of bacteria that we all carry is we have barely cracked the surface on the significance of the microbiome in my opinion.
That's interesting.
But my point is only to say that all these different formulations of probiotics, some people feel better, some people don't, and I say if you don't, maybe look elsewhere.
So that's no excuse for people to be ripping like 5 yogurts a day, is what you're telling me.
I guess if you really like yogurt.
Yeah.
But then they come in with their dairy intolerance.
Right,
So-
exactly. Lactose
Well, what are you
intolerant.
doing? I'm having 5 yogurts a day.
It happens. 100%. All right, next
right.
story. Exclusive. From Reuters, U.S. to drop guidance to limit alcohol to 1 to 2 drinks per day, sources say. So the U.S. government is expected to eliminate from its dietary guidelines the longstanding recommendation that adults limit alcohol to 1 to 2 drinks a day, according to sources familiar with the matter, and what could be a major win for an industry threatened by high scrutiny of alcohol's health effects. I was really shocked by this, to be honest with you. When I was doing my MPH, okay, there was a time, I know you remember this, Dave, you probably remember this too, where doctors were telling people, have 1 or 2 drinks a day for metabolic benefits, right? There was this school of thought that alcohol improved lipid metabolism and insulin resistance. And I met one of the researchers at Harvard that did one of the big studies that was like the champion of this thing. And I never bought it. And I remember in class, I questioned him to the point where my cohort, some of my colleagues were like, wow, you really questioned him? Like, yeah, because it's BS. That's why. But the whole idea that alcohol is healthy for you in any dose is just not backed up by what we've seen in the data. And you know that as a gastroenterologist.
That's right. We know it's caustic, right? So it's caustic to your stomach lining, your intestines. There's an increased risk of GI malignancies with alcohol consumption. And by the way, that's multiple. That's gastric cancer, colon cancer, pancreatic, esophageal. I mean, it just goes on and on. And it's, again, probably because it's irritative, not helpful. The only thing that I remember, and you're more into this, would be my super shallow dive, would be some of the old red wine studies, right? With some like vasodilatory effect or whatnot. But
It was an antioxidant. I think it was called resveratrol.
Yeah,
but
that's
to
right.
order to
Resveratrol.
yeah. But in order to get the dose,
very high. So
you
they
had to
tried
be
to
like-
formulate
yeah.
it into pills. I
Right,
remember a long
right.
time ago, and I don't think it ever panned out.
the bottom line is like there really is no safe level of alcohol consumption for health risks. Now, I will say that if you're drinking a drink or two, a couple times a month, the risks are probably nominal. But to tell people to have a couple of drinks a day for the health benefits, that was insane medical advice.
So why are they getting rid of it? The lobby?
I think so. Yeah, I think lobby and just, I mean, I don't know, money
Doesn't feel like the right recommendation.
It
to be
does.
making.
That's what I feel. That's what I'm saying. I mean, shouldn't we be going the
So
opposite way?
they're not, yeah, but they're not telling us what a healthy amount of alcohol is to drink,
I
right?
guess
They
they're saying
just
more
drop.
than 1 to 2.
They're just not going to recommend anything.
Well, I mean, nothing is maybe better than somehow if people take away from this. Oh, great! I better have 3. I better have 4. But
right.
yeah, I mean that's lunacy. Although anything I think a lot of the maybe myths come from the fact that we look at Europeans and they tend to be more relaxed and in some cases thinner than Americans. But I tend to think Americans are obese for different reasons than just alcohol. But in other words, we waste whatever benefits might be that the Europeans get. I don't know. Is there anything to that? You know, you go ahead.
That's a really interesting point, actually, because I get patients that come in not infrequently. Had one today in my clinic session that says, I have got these gut problems and my bowels are irregular and I have reflux and this and that. And they say, I was in Italy for a week.
Yeah.
Didn't bother me at all.
Right. Interesting.
Right? And what's the reason? It's what you're saying.
Yep.
Even Italian wine
Right.
or French wine is made in a very different way than it is in a lot of places here. Not everywhere here, but a lot of places with preservatives,
Right.
etc.
Less
And I
processed.
think I have a patient who can't eat any bread here. They go to Italy. Every night they're
That's
having
interesting.
and they feel fine. And it's probably because of what we're
The way
talking
our
about.
food and also our
that's
liquor is prepared.
That's
yeah.
right. That's right. And I think we overconsume in this country. I do think we
for sure.
overconsume
Everything. That's
right.
part of
but,
that's
but,
part of
but
what we
that
do.
is, I don't know. That's suspect. I think.
I think it is. It just sounds like the U.S. is basically throwing up their hands and saying, "Hey, party on,
do what you-
everyone! We lost. Party on." Okay. So next one. This is an interesting one. Trump diagnosed with chronic venous insufficiency. This is from the New York Times. Obviously, it was everywhere. The White House said on Thursday that President Trump has been diagnosed with chronic venous insufficiency, a condition that occurs when veins have trouble moving blood back to the heart. The only thing that I really found interesting about this story is the fact that it was such a big deal. Like, what is remarkable about a 78-year-old guy
Exactly.
that has venous insufficiency?
Right.
Nothing.
Most people almost 80 are going to have probably some varicosity or some insufficiency, I would think.
Yeah. And it's like, yeah, okay, they did the test, right? You want to make sure that their heart is pumping correctly, which they did the echo, it was fine. And, I mean, obviously, the only thing I can think of, Steve, is that, like, obviously, if you have venous insufficiency and you're walking around with big balloon hands or balloon ankles, like, people might notice that. So maybe they needed to just put this out there to, like, abate speculation about his health. But it's like, I mean, everyone in my office over like 70 has some venous insufficiency.
Strange.
Well, the conspiracy theorists would say anything they throw out now is to deflect from something they don't want to talk about.
yeah, that's
So,
fair.
although Trump doesn't like the idea that he's in poor health,
I know. That's true.
he's fit as a fiddle.
Yeah.
It's the
Stay tuned.
Oh, yeah.
KFC
Well,
diet.
that's just it. They say in the story, they're like, everything continues to show the president is so healthy. It's like, listen, you can say that 1,000 times. I'm not buying that one. The guy's a ticking time bomb. All right, let's go to the next one. Another
Not
Trump.
ticking quickly enough.
Oh, that's your opinion.
Sorry.
I'm not saying I disagree
Politics
or
up.
disagree, but I just don't want anyone to be offended. All right. The one big, beautiful act signed into law by President Trump on July 2025. Now, this is interesting for us because this will impact the way we get paid. And I think it's going to be a mixed bag for us. How is this going to affect physician reimbursement? And let's be honest, and you know this, physician reimbursement affects everyone because how doctors get paid affects how doctors practice. It affects your ability to get an appointment with a doctor. It's just the reality of the situation. So I think that the implications this act could have on, healthcare is significant.
Absolutely. I think there's a lot of possible downstream negative effects of this, all the way to the point that I've talked to emergency medicine folks who think that this could lead to hospitals being able to say, we're not taking care of
Right.
patients anymore who are uninsured.
Scary.
And that actually is, people aren't talking so much about it, but that is potentially a huge problem. And it really dichotomizes our population to those who can actually receive care,
Right.
and those who can't. And it puts us in a different standing in the world, right? Now, if you get hit by a car, you're going to be brought to the hospital, you're going to get taken care of, right? At least acutely. And that could change.
Yeah, and so some of the ways this is going to affect physician reimbursement, on the good side, it will increase Medicare payments by 2.5% on January 1st. But let's be honest,
less than inflation, anyways.
that's 100%. That's the first thing I thought of. I mean,
It's
in
like,
Medicare
that's a
payments.
cut.
I mean, I don't know what it's like for a gastroenterologist, but let me
It's
tell
all
you,
the
for a
same.
primary care doctor, Medicare payments are terrible. Terrible.
You couldn't sustain a practice,
Nope.
only on that.
If I was really just like a strict cold businessman, I wouldn't even
I know.
take Medicare.
I know.
I mean, we take it, obviously, but we love our patients, but the payments are not at all sufficient for the amount of time we put into these complicated patients. But nonetheless, 2.5% increase. Excuse me. Next one. Medicaid cuts and the impact on providers, right? So they're going to cut a lot of the funding to mass health. So that's going to really affect how we get paid. I don't know if you have a lot of mass health or Medicaid patients, but a lot of these patients are going to lose their insurance.
Right.
now.
So what's the expectation? What are they going to do?
Right.
Do you know the answer?
I don't. No one does.
I mean, are they going to expand the Obamacare availability of public plans? But these folks aren't going to be able to pay for them.
Right.
So
Yeah.
again, I think this is going to widen the gap between the haves and the have-nots.
100%. And I honestly think that every dollar we put into making primary care and, other kind of available medical services accessible to people, that pays us back tenfold in the long run. So my concern when I hear this is we're taking a vulnerable patient population and we're making it harder for them to get care. It's actually going to cost us money in the long term. When all these diabetics have heart attacks, when all these minor GI bleeds end up having big GI bleeds and ended up in the ICU for 30 days.
Absolutely. And you wonder what's the driver of this, right? I think the motivation behind the folks that came, architect this was fraud and abuse in the system, right? And sure, I mean, there's some people that are on these programs that probably shouldn't be, and you want to try to go look into that more and figure it out, great. But to have such a broad brush and say we're going to defund these programs, as you said, it's going to hurt providers, it's going to hurt patients, it's going to hurt hospitals until people say we're not going to take them. Then people are going to have even a harder time getting
100%.
care.
And that's coming. And then the one good thing about the bill, one thing I did like about it, just to be fair, is it is going to make permanent telehealth services. And I think, and that's important.
Yeah.
That telehealth is a great thing. And I'll tell you, frankly, from my office, telehealth is a big part of how we're able to remain economically viable. So if we lose telehealth, I may end up having to go concierge. Like, not even kidding. Like, because I just don't know if I could make ends meet if I couldn't bill for phone visits. Because, so.
Well, for too long, I think, and this is a different conversation, but for too long, physicians have turned a blind eye towards fairness and valuation of your time.
Right.
And I think that the generations that came before us had it very differently, the way that they practiced medicine, the way they were treated, the way they were respected. But if you look at other professionals, you call your lawyer, you call your accountant, you call your whatever, they're charging you for that time, right?
100%.
And how many years did it take for you to get to the point where you can answer a question in 30 seconds? It took you a decade,
100%.
right? And yet physicians and the healthcare system decided that expertise is not valued in the same way.
Right.
And so for you to say, I might have to go concierge, I mean, that's the trend. And that's the wave of the future for a lot of people.
You don't see many offices like mine out there anymore. They've all either closed or gone concierge. That's the reality.
Yeah.
And that's all economics.
It's a tough thing. And for folks who can get in and be taken care of in that respect, it works out great. But there's a lot of people that can't. And, and so bigger bigger problem on our hands.
And let me be clear too. Like, I don't want to go concierge.
Sure,
Like,
of
I
course.
like my patients.
Yeah,
I like taking care of my patients. But if we lost telehealth, I really don't think we'd have a choice. Like, telehealth allows us to bill for the time that we're spending. Like, we're writing prescriptions, we're diagnosing you, we're treating you in a way that is super convenient to the patient, right? We're providing a service. It's the only service we have, which is the ability to evaluate and manage medical problems. Of course, we should be able to.
And it
go
improves
forward.
access.
110%.
Right? So that's what I think, because it allows you to offer more spots. You can get patients in quickly. You can talk to them and feel good about it, right? That you're taking care of the patient in a way that's reasonable and timely. So yeah, I agree completely.
All right. Are we ready to move on to the non-medicine topic of the week? What do you think? Can we wrap up? Can the doctor go off?
Absolutely.
This is the best part of the show.
All right.
We've been looking forward to this. Let's do it.
Me too.
The doc is off the clock, so it's time for the non-medical topic of the week.
All right. Kick up your heels, sit down in the doctor's lounge, grab a cup of coffee, hope the pager doesn't go off. It's the non-medicine topic of the week. This is a no-brainer, this topic for us. This is the topic that everyone has been talking about. And of course, because we strive to provide comprehensive coverage on this podcast, there is no way we could let this go without mentioning, and that is the, now, I would say world famous Coldplay concert reaction. I have so much to say about this, but I'm going to start with this. Dave, I know you're a big music guy and you do a music podcast. Let me just say right off the bat that Coldplay has provided more entertainment for me and for the world in the last 3 days than it did in the previous 20 years. Right?
Yeah, with much more than they've provided for me musically. I don't know. I'm not a huge fan, but I think Chris Martin's a pretty funny guy. I liked his appearance on Curb Your Enthusiasm. And you're right. This is breaking records. I mean, we all say, well, everything, this goes viral, that goes viral, this is a meme, this is a GIF or whatever. I don't know. I've never seen one this pervasive, this funny. I got to admit, there were so many funny riffs on it, right? And then also, sadly, that it affected someone's life as much as it did, right? Yeah.
Well, I don't know if you guys have a favorite one, but I think you hit it. Like, have you ever seen anything good? This is the definition of going viral. I can't remember anything else that went viral like this.
Yeah.
It's wild.
Yeah. And then all the parodies are just, the one I laughed loudest at probably was, I think the Philadelphia Phillies got on it first with the Philly Fanatic and Mrs. Fanatic reenacting the moments. I mean, that was great.
Do you have a favorite meme, Steve?
That was a good one.
Yeah.
I like that one, actually.
Okay.
I mean, there's there's everything. There's Obi-Wan Kenobi. And
that was a great, I was going to mention that one.
Yeah.
That was one of my favorites. Obi-Wan and Padme.
Yeah.
I saw Trump and Nancy Pelosi.
I didn't see that one.
I
That's
saw
a good
Trump and Rosie O'Donnell. What else? There was a couple other terrific. I saw the Scream from Edward Munch.
Yes.
But it was just the two. It's like people got really creative.
Dwight and Pam from The Office.
Dwight
if
and
you're a
Pam
fan.
from The Office. It was everywhere. It was unbelievable. I really think like this is gonna that reaction is gonna be up there with like the lady, the meme with the lady with the cat and the cat that went everywhere.
Yeah.
This is gonna be right up there.
I
with
think
that.
it's maybe the biggest. But what do you guys think in terms of, is it a sad? I mean, we're all having fun with it, and we figure nobody died, so it's okay to make fun of it. But two people's lives are irreparably changed. Is it, I don't know, is it fair? Is it a sad commentary that something like this happens?
I don't think so. I think in some respects, society needs this stuff.
Okay.
Don't you think?
Yeah.
You know what I mean? It helps us along a little bit. And I don't feel bad for that. I mean, I feel bad for I don't know about his background, but I feel bad for the families more than anything else. I mean, like, what are you doing? What are you doing?
It was a really stupid move.
You know, it's like that old risk management saying, like, be smart when you're being stupid.
Yeah,
Yeah.
right.
Right?
Well,
and that really wasn't it.
Yeah.
if they just played it cool,
Right.
nothing would have come of it. Literally, this only happened
Right.
because of the reaction.
Yeah, that's right.
You know,
So dramatic.
I mean, I don't know if you guys have. I've worked in offices where there have been funny business, or at least rumors of funny business, and usually it's office gossip and it's good for a laugh. And sometimes people get very uncomfortable with it. You know, it's like, don't be spreading those rumors about me. I have a wife at home. But the thing that was maybe unique about this one was there were other people in the luxury box that I guess were coworkers that they weren't surprised at all. They laughed.
I know. What was this one? Someone was like,
Yeah.
You saw it?
Yeah.
Yeah. So, well, what's your theory on that?
I don't know. I mean, some people just must have known. It was like I feel badly for the girl that was smiling next to them because I don't know what she did at all. It just happened to be standing there, and people like got all these weird conspiracy theories about this poor girl.
I know. Leave her alone, especially. Yeah, she didn't do anything. But you just wonder if it was, some people are married and then it's sort of openly, maybe they're unofficially separated. We don't know for sure what they're.
Right.
But apparently they weren't separated. Apparently they were married. They're both married to other people. But apparently no one in the office. But if you're canoodling with your HR head of HR openly in a suite with your coworkers, then we go back to what you said.
Do you think she did his exit interview? Yes. From the HR standpoint?
It's very awkward, I think. Yeah.
Very awkward exit.
Yeah.
Well, this will be quick.
No. Honestly, though, we talked, Dave's an attorney, and we talked last week about the Reed trial a little. And one of the things that I found concerning about that was the way that people were just thrown out there on the internet. And it was kind of like judge, jury, and executioner. And I do feel the same way about this. The toothpaste's out of the tube, so we're talking about it. But like, there is something scary about the power of the internet to make or break people with no real like checks on that power, and just like this sort of like morally self-righteous authority that's like based on these collective values. And if you run amok of that, then you're thrown out there and just eviscerated. And I don't know, that's like Huxley. That's like a Brave New World.
Yeah.
It's not coming from the government. It's coming from us. But I think it's scary.
And it's sad because sometimes it's for the good and sometimes it's not, right? I mean, sometimes it exposes real wrongdoing. Sometimes it celebrates heroes appropriately, but sometimes it just gets it wrong, and it's scary.
It's not always wrong to have an extramarital relationship. I mean, if it's a bad marriage,
right?
I mean, sometimes people are doing the right thing. I'm not saying I condone what they're doing by any means, or that I would do that. If my wife's listening, she might kill me for what I just said. But it's not always wrong. It's like it's wrong, I think, to judge people when we don't really know what their personal experience is.
It's
and that's
not
what's scary
It's
about
not
it.
our business, right? It's like they who knows what's going on exactly in their lives, and it's just sad that everybody. This is what I was saying. It's sad to be in an office for one thing where people are like speaking ill of you. I mean, like I said, I've seen those situations before, but now you got the whole country talking about you. It must be very deflating. I guess. What's the possible upside for them? Reality show, maybe?
100%. They're going to parlay this into something. I mean, he resigned.
Right.
Do you think he should have resigned? I'm not. I have mixed feelings about that.
I don't know. Maybe wait to be fired and work out some kind of severance, or maybe he did get some kind of severance. I don't know, but yeah, he had that was a $1 billion company, right?
I mean, he's not the first CEO to have an affair.
I guess it was the fact that it was a coworker is
who happened to be the head of
damning.
HR. It's like the worst possible.
Yeah, exactly.
Right.
Rough.
Yeah.
Well, that's it. That's our take on that, and certainly like one of the most notable stories. But one thing I've learned about this country right now is we have short memories. This will be something people won't forget, but people are already moving on to the next thing.
Yeah.
So they had their 2 or 3 days in the hot seat, and that'll be that.
We'll have a new meme by the next time we record the show, right?
10,000%. All right, Dave, let's wrap it up with very quickly the Boston Sports Minute.
Sure.
Take a second to talk about what's going on in the world of Boston sports. Where are we?
Well, I don't have anything new on the Pats. I don't know if you do.
Training camp opens on Wednesday.
Yeah, very excited. I can't wait a month from now we'll be probably have an exhibition game or two to talk about. Still expecting a championship season. No, hopes are very high. But I'm excited the Red Sox are relevant again. Who knows? We were so excited who saw a 10-game winning streak coming?
Well, when we recorded last time, they were tanking.
Exactly.
And then things have really changed. But I don't know. Is it fool's gold a little bit?
A little bit, but at least it stands to be a fun summer. I don't know if you caught the game. Yeah, as we record, we're recording this on a Monday. It was yesterday, right? It was yesterday. Yeah, they managed to salvage the last game against the Cubs, and I happen to be watching this part live where close game 2-1. Alex Bregman apparently was given the day off, wasn't expected to play. Apparently persuaded Cora to put him in, and they're talking about, oh, this is unusual. He was supposed to have the day off. The second pitch he faces, he smashes it out of the park. Just very exciting. And you could see the kids are jumping up and down, and Bregman seems like the right leader at the right time, maybe, even though it's his first year.
100%. What should they do with the trade deadline?
Yeah, I like everybody else. I'd like them to get a pitcher. This guy Ryan maybe is the guy. I want them to get Joe Ryan because this is a little off the beaten path. But my brother Adam sings in a rock band in San Francisco, and they're called Leatherfeather. And Joe Ryan warms up to a Leatherfeather song.
Oh, no
it's
kidding.
his favorite thing.
Oh,
so that's why I'm rooting for him.
I like that.
But I don't know. I mean, yes, I think maybe you agree to this. They have to make some move in order to. I mean, we could squeak into the playoffs, but if you're really serious about going for it this year, I think we need some pitching and maybe another slugger.
Yeah.
I don't know. What do you think?
I think this is really what I think. See, I disagree. I think they should just stay where they are. I don't think this team is built to be a World Series contender this year. I don't want them to trade Jarren Duran. That is the one thing more than anything I don't want them to do. You can't trade a 5-tool player like that who does everything, field, catch, hit, everything. I would think that would be a huge mistake just so you can turn from an 86-win team into a 90-win team or something like that. It's not worth it. I think this is a developmental year. I'd like to see them make the playoffs. They got a ton of exciting young players. I think they should just roll with what they have. If they can trade prospects and bring in someone relevant, fine. Don't trade any of their real core assets. I think they'll regret it in a couple years.
I mean, now it's to the point where even though we don't have, with the possible exception of Bregman, it's not like we have Hall of Famers in the lineup, but the outfielders are going to have battling for time now. We have guys who have had their moments, and with the exception of maybe Connor Wong is the only guy that you kind of can't stand seeing him at the plate. But like everybody else has had their, Romy Gonzalez and Ref Snyder, and then of course, you got Duran, you got Christian Campbell's going to be back, and the thing that I look at is if they keep up with these, you need starting pitching, right? Well, their 3 best starting pitchers right now are all under or 30 years old or younger, right? Crochet, Bayo, and Giolito.
Right.
That's a good foundation.
That's a good foundation. And maybe Tanner Houck comes back and gives them something. But, I mean, look, Roman Anthony is a star in the making. He's hitting the cover off the ball. It's exciting. Bregman, Masashita coming back. I think they have a good, deep lineup, and I really think they'll have a good season, but I wouldn't go too far. I would just let it see what happens. That's really what I would do with the trade deadline.
He has spoken. Therefore, that's the correct answer.
You don't seem like a sports guy. You didn't chime in on that part.
No, the truth is my Red Sox fandom has waned in the recent years. I do think that I'd like to see them be a buyer right now. I think that, and I think they're thinking about ticket revenue from a playoff series.
Well,
and that's enough to push them maybe. But I agree with you. I mean, to get rid of any of the young talent would be a mistake.
Yeah.
Well, there's been so much cynicism, and perhaps justified, that they haven't gone out and spent money the last couple of years, and they're only interested in the bottom line. They're only interested in the soccer team. It's interesting how winning cures that. People, when you win a lot of games, people will forgive that. And
100%. I'll tell you right now, just to give you, and we'll wrap up after this. After they traded Devers, I was so mad I said, I'm not going to another damn game this year. I'm already looking at tickets in August now. They're playing good.
Just when you think you're out, they suck you back.
100%. It's the story of your life if you're in New England. All right. Well, we want to thank everyone that listened to this episode of the Modern Medicine Podcast. Thank you, Dr. Stephen Rotman. Great doctor, great gastroenterologist. For anyone that needs him, find him in Needham. Look him up. He is terrific. Dave Yaz, our producer. Thank you. Have a great month, everyone. Be safe, be healthy, be well, and we'll catch you next time.